All right, guys, we're going to get started. Good afternoon. I'm Olivia Hunty from the New England QIN-QIO, and I will be moderating today's webinar. Thanks for joining us today on HHQI Partners in Quality of Care, how to access and utilize HHQI reports for data-driven improvement. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of the webinar. The phone lines will be on mute for the duration of the presentation, and we'll take questions at the end, and I'll provide you instructions on how to unmute your line. At this time, I'm going to introduce today's speaker, Roby. Kathy is the Connecticut Home Health Lead for the New England Quality Innovation Network Quality Improvement Organization. Kathy is a registered nurse with over 40 years of experience in home health care. She specializes in quality management, improving home health provider clinical outcomes, and reducing acute care hospitalizations for Connecticut home care providers. Please welcome Kathy Roby.
Good afternoon, everyone. I hope that the sun is shining in all 6 states as brightly as it's shining here. It's a big change and much welcome from yesterday's sloppy mess when we were all trying to drive home. But at least we have a little tiny bit of snow so that we can finally feel like it's winter in New England. Today we're going to talk about the HHQI website. This is a program that was requested by a number of people who were anxious to know what the HHQI website could do for them and how they can access and use the reports, the resources, the information that is there to create a data-driven quality improvement plan. We're going to spend some time talking about different parts of the system, the HHQI website. We're not going to access the website live. I believe that most everyone has at least found it and located it. But once you get there, we're going to show you some of the reports. We're going to talk about how you would read them, use them, and create a performance improvement plan utilizing them. Today's program, as each of our monthly programs has been, is brought to you by the New England QIN-QIO. It's an alphabet mouthful that means we are a quality innovation network dedicated to quality improvement. This is a joint venture project between health-centric advisors in Rhode Island, who is taking primary responsibility for working with Massachusetts, Maine, and Rhode Island, and Qualidigm here in Connecticut. We are working with the home care providers in Connecticut, New Hampshire, and Vermont. We have a website. All of the programs that we've done each month for, can you believe it, 1 full year today, each of those webinars are currently saved on that website. You'll be able to go to that website. We will show it to you momentarily. And when you get to that website, you will be able to download and reuse as often and as much as you need to all the different webinars that we've recorded and presented over the last 12 months. So once you get to the QIN-QIO website, you're going to see the tabs across the top. Just slightly left of center, you'll see a tab that says For Providers. This is where we are housing webinars and all the other information that relates to those of us who actually deliver the care. When you click on that tab, you're going to see a drop-down, and the drop-down has Home Health, second from the top. We're moving up in the world. Notice that we're above the hospital and nursing home people. It's a nice place to be. And you will find that when you click on the Home Health bar, it's going to show you information that is directly related to what we are doing as home care providers together. When you've clicked on it, you're going to see events on the taskbar, and you will notice that on this page now, you have upcoming events on the left, and in the center, below the home health paragraph, you have a list of all the different webinars that have been presented so that you can click on them and reuse them for staff education. There is a representative from each and every state that is ready, willing, and able, and available to work with the home care providers in that state. We've provided you with the email addresses for everyone for each state. Please reach out to us. We are more than happy to schedule a time to come out one-on-one, on-site to your agency if that's what you feel your agency needs in order for you to select a measure, for you to develop your performance improvement plan, and move forward in improving cardiovascular health in your home health population. If you feel that a conference call will work, give us a call. We'll schedule one for you. If you would prefer to have us do just a one-on-one call with your person who is the resident champion for this project, we'll be happy to do that too. So please, take note of the person for your state, give them a call, and let them know what it is we can do to help you. So let's begin today talking about our topic, home health quality improvement and you and your agency. We truly are all partners in the quality of care. And our topic today is how our contact people, our resource partners at HHQI, are going to help us with the data reports that they've provided and all the other resources on that website. We're going to identify exactly what HHQI, Home Health Quality Improvement, the website itself is, why it's important to you. We will identify the resources that are there, look at what kinds of data are available to you, and then we're going to walk through a performance improvement process using that data, focusing on a specific outcome so that you can see how it will help you. There on your screen is the hyperlink. If you have downloaded the PowerPoint slides that were sent to you, you will see that this is the website and it will take you directly there so that you can get your agency registered if you've not already done so, identify a contact person, and get yourself a password. That will give you access into the data reports themselves. This program, this website, originated almost 10 years ago already. This goes back to what is known as the 8th scope of work. We are currently in the 11th scope. So that was 3 projects ago, and as I said, it's almost 10 years old already. This initiative was intended to be, according to CMS, a commitment to providing educational resource and support and guidance to home health providers so that they could succeed in the specific projects they were working on. It's a national campaign dedicated solely to improving the quality of home health care. It is specific to us, not something created for hospitals or nursing homes, but something created and geared toward us, which is certainly a very important aspect because that means the resources and the tools are going to be easily picked up and simply implemented. They won't need further adaptation to be used in patients' homes. It's also providing you a source for timely, accurate, targeted data. You will see that all of this data is based on your Oasis information. You've collected Oasis data, you've submitted it through Haven, through your EMR system to CMS. Once you register and pull up a report for your agency from one of the different ones on their menu, you're going to see that now they've taken your data and sorted it in ways that you may have always wanted to be able to look at, but were not able to quite figure out how to do that in a tele report on the CASPER website. So this is going to make it a bit easier, at least in the areas that HHQI is focusing on. These 2 wonderful ladies are our contact and resource people in the HHQI project. They are our team leaders for for the project to improve cardiovascular health. If you have an issue, if you have difficulty with your password, you can't seem to get onto the site, can't get your reports to come up correctly, call me first. If I'm not able to help you, then please reach out by email to either Cindy or Misty, and they will be happy to help you. Cindy's email is csun@wvmi.org. And Misty's follows the same pattern, mkedech@wvmi.org. So please, if you're having difficulty accessing your report, reach out to HHQI, reach out to them, and they will help you. They are very prompt about getting back to people. They're very excellent teachers. They have done many of the programs themselves that you'll find on the HHQI website for training materials for your staff, and you will find them very user-friendly. On the website, and again, this is a live link, you go to the homehealthquality.org to the education section. This will take you to 3 specific areas. The HHQI University. In the HHQI University, there's a very large number already, and more being added every single day, online learning courses. These are appropriate for your clinicians, for nurses, therapists, social workers, and many of them, over 50% of them, come with CEUs. So if your state requires CEUs, this is an excellent, cost-free resource that will enable your agency to provide CEU education on a regular basis at literally no expense to you other than providing your staff with the link. They can do it directly, independently, or you can set it up on site in your conference room and have them do it together as a group. Whatever works best for you. But this is an excellent, excellent resource. There is the best practices section. We've spoken about this before. Each month, the HHQI staff has a focused area that they are working on. In this focused area, they will create what is called a best practice package. In the package, you have discipline-specific clinical resources. In past months, when you go back to the QIN-QIO website, you're going to find that we have focused on different topic areas in improving cardiovascular health. One month, we spoke at length about smoking cessation. If you were to go to the best practices area at the education tab, you would find a BPIP, a best practice intervention package for smoking cessation. In there, you would find a module for administrative and supervisory staff that focuses on what you need to be saying to your staff, how you need to approach it to make this a priority for them. For the clinical nurses, it's talking about the clinical piece. How does smoking affect the general cardiovascular health of your patients? What is the impact? How would you assess the readiness of a person to stop smoking? How do you assess the readiness to even have a conversation about this very touchy topic? I know I'm a reformed smoker myself, and if someone had tried to broach that topic with me 30-something years ago, they might have gotten hurt. It provides the same type of a module for physical therapy, medical social work, and because they consider them to be a critical element in your team, there's a separate module for home health aides themselves. This will enable you to bring this to each part of your clinical team. If this is a measure that your agency is going to work on, you're going to improve your percentage of success in getting your patients to stop smoking. At least reduce the number of cigarettes they have. Something in this area. You can tailor the education, tailor the approach to each specific discipline. In addition, because population health is such a critical issue, the best practice packages are now including specific materials and education and training for your staff on patient engagement and a population-based approach to how you present this topic to the patients and to the staff. And finally, because it is, after all, our patients, the consumers, that we are trying to reach, whose behaviors and general wellness we are trying to improve, there are over 50 patient-specific, culturally and linguistically appropriate tools that you can print down, copy, save, distribute at no cost to your agency, and they will provide a tremendous amount of material. And this brings us, at long last, to the link that will take you to the data reports themselves. As I said earlier, these reports are all based on Oasis data that you have submitted to CMS. This data, in turn, comes back through HHQI in these 5 areas, and it is then broken out by the agency. Your individual agency's data is then reanalyzed in at least 5 or more different breakdown ways that will enable you to have a much better understanding of your results compared to your individual state and national benchmark data. Again, this is an active hyperlink. So if you have a copy of the slides on your screen, you can click on this link. It's going to take you directly there. Note, please, that it says it's a secured website. This is where it becomes important that you remember what your individual user ID and your password is for the person you selected as the responsible contact person for your agency. It's up to you to decide how many people will use that single user ID and password. I would obviously not be posting it on the bulletin board, but there is nothing wrong with the quality manager, the administrator, and 1 or more clinical supervisors having access to this data, because it's going to help them a great deal as they review the reports and look at what this data is telling them about the care that you're providing. There are 5 reports, as I said. The first and most important one, I think, is the acute care hospitalization, and we are going to look at this one first. The second one is oral medication management. The next 2 are influenza and pneumococcal immunization. And lastly, because as I said, we are trying to take a population health-based approach, cardiovascular risk factors are analyzed for your specific agency. This is very important information. If you know from your CASPA report that the case mix for your agency tells you the average patient is in their early to mid-80s, has limited support systems, is obese, is a smoker, is a minority, has limited financial resources. What is this telling you? Your case mix report is not going to give you all those factors. Your case mix report will tell you the average age, how predominant a specific diagnosis might be. If you know how to do the tally reports effectively, you should be able to identify what specific functional limitations are most common. But it's not going to give you the population health information about your particular caseload. And that's where this particular report becomes very helpful to you. Here's the first of the reports. With acute care hospitalization, what you have at the top of your screen is month by month, you are looking at the raw number of hospitalizations on the top row. The second line is the total number of transfers and discharges for each month. Below that, what percentage do the hospitalizations represent of those discharges? and then it looks at your state percentage and your national percentage as compared to yours. You can then look at those in the graph below. In this case, if you look at that graph carefully, you're going to notice that the state and national rates, the green and blue lines, are a mirror image of one another. But this agency's rates are different. In August, they had a peak high. In April of 15, they had a very precipitous drop, which they weren't able to hold on to too well, but it's not terrible. It would be of interest, if I were the quality manager there, it would be of interest to me to know why I had a sudden spike in August of all times. It's not a prime month for influenza or pneumonia, and yet there was a peak in the hospitalizations. Perhaps there was a heat wave. This would have a negative significant impact on CHF and COPD patients. The next graph below that is going to break down the percentage of those admissions from the top graph by the day of the week. It does exclude planned readmissions, but it looks at how they break down. And this can give you some really very fascinating information. In the grid above, we noted that in August, there was a spike in the agency's readmission. If we look at the bottom graph and look at what day of the week did that happen, we have increased numbers. However, we had more than double the admissions on Friday in the month of August than we did in the month of July. I wonder how many physicians were on vacation or had long weekend plans in the month of August, so that might just account for the fact that they didn't want to see anyone in their office, and they simply responded to calls with issues by instructing the patient to go immediately to the emergency room. That would certainly give you that spike. Let's take a look at the monthly report for improvement in management of medications. This report is again looking at what raw number of individuals improved in their ability to manage their oral medications, as a percentage of the total discharges, the agency's percentage of improvement, and then the state and the national. In this instance, the agency's percentage of improvement is much higher than the state and the national, but it's not able to retain that rate. It is up and down month over month. When you see unusual changes, spikes up and down, negative trends, this is an indication that you obviously need to do further investigation. It does look at, in the bottom, it sorts it out by the actual answer, that the question was not assessed, there were no problems found, or there were problems found. If you know that you are finding a great many problems, then you need to be looking back at why did we discharge these people? And were the people who were having medication compliance issues, their oral medication management was not going well? Are these the people who account for a large number of the readmissions? Because medication errors or problems are a known factor in causing readmissions. So those are some of the questions that you're going to ask yourself when you look at this information. And in a moment, we're going to look at how we would take these reports and then turn them into a quality improvement plan. Here's a sample of your influenza vaccine report. We know that flu vaccine use is going to be a part of, it's currently part of STAR, and it's going to be a part of your home health value-based purchasing scores. So this will matter a great deal. Certainly it makes sense that the amount, the compliance with getting immunizations done is going to be much higher from October through March or April, and that influenza immunizations would fall off in the spring and summer months. When you look at the Pneumovax, this follows a more logical pattern for this particular vaccine. Again, because Pneumovax can be given at any time of the year, but it does peak in the fall months. Unusual here that it was so low in January. So you might want to be looking at that if this were truly your agency's report. Here's the first page of the cardiovascular risk report card. The risk factors for cardiovascular disease are listed on the left. There's obesity, smoking, and then those patients who have both of those issues, both obese and smokers. So that this information is gathered from your Oasis question answers, and then it is looked at as a percentage of your discharges. And then it's graphed out to show what percentage you have for each of these factors. So you have all these reports, and I'm sure that also on your desk you have not just these reports, but you have other Oasis reports, you've got CASPER reports, you've got Home Health Compare, you have your patient satisfaction HCAPs, and Lord knows whatever else. You are definitely already drowning in numbers. Reports of every stripe, color, kind, and shape. And if you're drowning and going down for the third time with all these reports, how are these HHQI reports going to help you to improve the quality of care that your patients are receiving? How is this going to help you to improve the actual patient care outcomes? It's a puzzle, and we're going to figure out how to solve this puzzle using these reports. Once you have set up a user ID and obtained a password for your data on the HHQI website, go back in, go to the link on the earlier slide, and run the acute care hospitalization, oral medication, and cardiovascular year-to-date reports. Look at these reports carefully. See if you can identify a potential problem area that is affecting your outcomes. If you're able to identify something in those particular reports that has an impact on your hospitalization rate, your emergent care rate, your oral medication improvement, then you can create a plan based on that information to reduce the impact, which in turn will reduce the problem level and improve your outcome, assuming that you are able to successfully educate and implement the plan with your staff. You will be able to gauge your success by carefully repeating the report runs and reviewing them month over month to see what the trends are. So let's walk through a process. When you run the full acute care hospitalization report, we only saw the first page, but when you run the full report, further down into this report, it's going to list out the causes month over month. It's going to list out the causes for what are the percentages for each cause as a reason for readmission. What is it telling you? If the two highest percentages are marked off as other or unknown. I'm not quite sure if either of those have an ICD-10, but I haven't seen one yet. If the next two in line are respiratory disease and CHF, it would be far more helpful for you if the percentages assigned to other and unknown were down at the bottom. You need to absolutely know what the real cause for the readmission was. That can be very difficult when you come in on Monday or Tuesday and you find that your patient went in on Saturday night. You only had the information from the home health aide. I went to the door, rang the bell, somebody came to the door and said she's in the hospital, so I'm letting you know. That doesn't give you a cause. And unfortunately, the transfer Oasis very often is simply checked off as unknown and turned in. You also want to watch your occurrence date. Part of that is weighting heavily into Monday and Tuesday, because that's the date that the clinician found out about it, and they put that as the date that it occurred. Not the fact that it actually happened on Saturday or Sunday, but I found out today, so I'll mark it down as today. We do need to know exactly when it happened. Otherwise, you won't be able to tell if this is an extended hours issue, or it's an access to physician issue, or what the potential causes might be. So carefully look at each of the causes, making sure that you have true diagnoses, even if it means calling the hospital, finding out what the admitting complaint was. 45% of the return to the hospitals are Medicare as a combination of fee-for-service and HMO. Be careful to make sure that this is correct information, that when the Oasis is completed, that you had the right payer source, and that you have the correct information here. What does it tell you if your risk-adjusted rate is 3 to 5 percentiles higher than the state and national rates? It tells you you have a problem you need to fix. You need to be as close to the national rate, if not below it, as you possibly can get. Try to get your reasons for admission to the hospital that are listed as other and unknown down under, I know the slide says 12, that's what's recommended, but I encourage you as an agency, try to get it down around 10% or lower if you can. The lower it goes, the better your data. Once you know approximately how many were respiratory or CHF readmissions, if the report tells you 10% of your 115 readmissions in the month of December were for respiratory disease, then you need to find those 11 records and you need to pull them, review them, and figure out whether or not this was preventable. And the same is true for the other causes of readmission, at least the top 5. If the readmissions are truly occurring on Monday, is it because there was a lack of staff response or availability for calls and visits over the weekend? Would a phone call or even a visit on the weekend, first thing Monday morning, Friday night, would that have prevented a readmission? Again, wherever the peaks are, this is where you need to find out which charts they are and do an actual dive into that chart to determine, is it preventable? What do I know? What are the factors? And how could I have changed this outcome? Or could I? Because if the patient fell and there was no throw rug, there was no door sill for them to trip on, they simply lost their balance and they fell. Those things happen. That might not have been preventable at all. They had an asthma attack. What caused that? The grandson came over with the dog that they happened to be allergic to. That is preventable with proper education and a little intervention. The answers to the questions are going to help you frame your first improvement plan. That's why we have these questions. That's why you need to frame your plan based on the information you gather, first from these reports and then from your deeper dive into the charts themselves. So how are you using this information to establish a plan? When you create a performance improvement plan, you don't want to have too many goals and objectives. If you have too many, you're diluting your efforts and it makes it much too difficult for you to be successful in accomplishing those goals. In this case, I would stick with these primary three. I would focus on reducing the unknown and or other ACH reasons, get them down as close to 10% or lower as you possibly can by reviewing your process for determining what the cause was, what is put on the transfer Oasis, and doing that through an intense review of the charts and the transfer Oasis data itself. You need to educate your staff. Remind them they should be calling the family, calling the hospital, calling the physician to get the information and documenting an accurate reason for the admission. Otherwise, you don't have valid data, and you can't build a plan on unknown and other. Your second goal is going to be to identify the precipitating cause for respiratory and CHF hospitalization events. There's a big difference between precipitating and predisposing. The predisposing cause could easily be that this is a New York Stage 3 CHF patient who's fragile at best. This person had an upper respiratory infection. They missed a dose of antibiotic, missed a dose of their diuretic, and they slipped into failure. That missed medication is the precipitator. The underlying chronic illness is the predisposer. You need to identify the precipitating cause for the respiratory or CHF events that caused the hospitalization so that you can target those that were preventable with patient and family education and whatever other interventions you might find that would be helpful. Finally, in Goal 3, you want to focus on those at-risk respiratory and CHF patients so that you can clearly identify them and then schedule their follow-up in such a way that those who will clearly benefit from extended hours contact are being reached. One of the ways that you can do this is by looking at how you schedule your new admissions. You have an at-risk respiratory or CHF patient. They come home. That is start of care day 1. These patients are so exhausted from their admission and from getting home, it's almost impossible to effectively complete the admission process in the one visit without being there for 3 hours. Consider, get your consent, do the primary assessment, come back on day 2 to finish. Make a phone call on day 3. If necessary, visit on day 4, phone call day 5, phone call day 6, visit day 7. You can reduce the visits if you use telehealth, if it's safe, but make sure that those phone calls and the contacts are there. Notice I numbered the days, not the days of the week, because if a visit day is a Saturday, it's a Saturday. It's the extended hours follow-up that is going to make the difference between an admission or someone who stays at home. And then what? You establish those goals, now what? Educate, educate, educate. Reinforce the need for getting those specific readmission reasons so you can improve your data. Review and realign the plan for your patients' visits and calls, just as I suggested. Look at the scheduling. Look at the alternation between visit and phone so that you can prevent the acute care events. Ensure that all of your staff, especially your extended hours people, are fully supportive of the concept of call the nurse first. If you're going to give out refrigerator magnets, that's what should be on them. Call the nurse first and a phone number. When your nurse is admitting the patient, once they get past, good morning, my name is Kathy. I'm going to be your nurse for this admission. The next thing they should say is, here's a phone number. Our agency is available to you 24/7. If you have an issue, if you're short of breath, if you're this, you're that, please call the nurse first, and there is always someone available to talk to you and help you to resolve your problem. You didn't just promise them a visit, you promised that you would help them. You may end up sending them in. You may end up sending a nurse, but you are there for them to reach out to, especially after hours. At the end of the visit, the last thing the nurse should be saying as she strolls out the door is, don't forget, I'll be back on whatever day, and if you need anything, call the nurse first. It will help to reduce your acute care hospitalization events. Once you've identified the predisposing and the precipitating events, focus on the care plan and care paths that you will find in the best practice intervention packages that are geared towards CHF and respiratory illnesses. These will help you to do targeted, focused education with your patients and their caregivers, medication education, and emergency triage, so they'll always know if they're in a safe zone or if they need help, and it will make a difference. So that's really what you need to know about the Home Health Quality Improvement website and what it can do for you. I know that it's January. I know that we're talking about HHQI today, but I want to go back one quick step and remind everyone about the Million Hearts Initiative. I'm not wishing time away, but February is American Heart Month, and we are committed to participating in the Million Hearts Project. We are committed to working with you, with your patients, and your staff. If you know from your HHQI reports that your patient caseload is at high risk because of obesity, because of a large minority population, if they have higher heart risk factors, remember, your patients will relate better to a suggestion that they switch this for that as part of a heart-healthy diet. They're sick to death of hearing about low salt and low fat. They're not going to go there. Low salt, low fat means they can never go to McDonald's again. They have a Wendy's they like to stop at. They're going to Kentucky Fried. Talk to them about how you can look at that menu. Get a copy. Put it in your bag. Look at that menu with them. Help them to select a better option. You're not scolding. You're helping to engage them in how they can address their obesity, their minority status, risk factors, so that you can improve their heart health. Help them to define their own goals so that they will do some physical activity. Don't use the word, you need to exercise. You're obese, you need to lose weight. They know that. They don't want to hear it and they're not listening. Find a goal that they have selected. Hopefully it involves some type of physical activity to achieve. Focus on the end point, the goal they want to get to. I'm going to get my own newspaper because otherwise somebody in the complex is stealing it. Okay, then let's walk out there and get it. I'll go with you. I know of several agencies who've decided that they're going to do an exercise walk at lunch. Taking 10 or 15 minutes of their lunch period, there's an in-house champion saying, I'm going to walk. We've laid out a route inside the building. So when it's 12 degrees outside, we don't care. We're going to walk 3 laps around at a slow, reasonable pace. No road runners need apply. This is not to win the marathon. This is simply to get up, get the blood flowing, get a little more oxygen to your brain. And it will work. And if you help your patients to see the connection between wellness behaviors and staying home, you will increase your chances of getting patient engagement at least tenfold. And you'll help your staff to buy in as well. We're hoping that those of you on this call, and we've had an excellent attendance today, I want to thank you all very much. We're hoping that as you are downloading the BPIPs, as you're looking at your data reports, that you will reach out to one another. I know that when we first started this call, someone fessed up to the fact that I've been in home health for 40 years. As embarrassing as that is, it does mean that I started in home health at a time when, as home care providers, we really did work together. We used to have co-op groups. 5, 6, 8, 10 agencies would come together. The clinical supervisors would gather once a month or every other month. We'd have coffee, we'd have Dunkin', and we would share what was working. Talk about care plans, talk about staffing modules, talk about visit frequencies and patterns. We can still do that. Yes, we are competing with one another. Yes, everybody wants to be the best game in town, so the ACO will love me better than you. But in the meantime, if we do work together, if you reach out to one another, if you're willing to open up your phone on this call today, just ask a question. Reach out to some other agency and say, we're having a walk every day at lunch. We posted quit smoking signs. We're using the call the nurse magnets. Anything that you can share with another provider is gratefully accepted. So we're hoping you'll reach out, not just to one another, but you can do it through me if you like. We are going to have Olivia open the lines for you. You can type into the chat box, I believe, or you can simply call in your question.
Thanks, Kathy. At this time, we'll take a few questions. If you would like to ask a question, please press #6 on your phone to unmute your line, or you can ask a question in the chat box.
We'll give that a couple of minutes so that if people have questions, they'll be able to go ahead and ask them. And while we're waiting for them to do that, I want to remind everybody that on the third Thursday of each month, Home Health QI offers an educational webinar. So please go to their website and look to see what the topic is for January 21st. It's at 2 p.m. And you'll also find there, as I said earlier, the archived programs that they have done in the past. Okay, I'm not seeing anybody in the chat box, and I'm not seeing anybody nobody's speaking up on the line yet. No takers. Don't be bashful. And as I said earlier, our emails were on a previous slide. If you're more comfortable that way, please reach out. Give us a call. Let us know how we can help you. There will be a Survey Monkey going out in the next 7 to 10 days. We are asking that you please respond to the Survey Monkey. We would like to know what method would be the most helpful to you for us to help you get started on your HHQI project, on selecting a measure, getting registered on the website. We'll pull down your data reports with you. But please answer the Survey Monkey when it comes out and let us know if you'd like us on-site, as a webinar with your agency, or as a conference call. We are happy to work with you in whatever way works best for your agency. And if there are no other questions, I'm turning it over to Olivia to close us up for today.
Wonderful. Do you have any more? I know that there's a webinar in February.
Yes.
Okay.
Yep, we are in the second week in February, we will be having another of our regular webinars, and it will be focused on February as American Heart Month.
Fantastic. Thank you all for a great discussion. I just have a few last-minute announcements before we end today's call. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would appreciate it. If you don't have time to fill out the evaluation right now, or you are currently sharing the computer with someone else, you will receive an email tomorrow morning with the link to the evaluation, as well as the link to the event page on our website. I've also posted that in the chat, so you can click on that link and it will take you right to the event page. The PowerPoint presentation will be posted on our event page by the end of the day. It's actually already been posted. And within the next few business days, a recording and a transcript will also be added. Be on the lookout for emails about our next webinar in February. And thank you again for attending. Have a great day.